In recognition of Stress Awareness Week, the NEI Podcast revisits a conversation that explores how profound psychological and physiological stress can manifest in unexpected ways. Join Dr. Andy Cutler and Dr. Joan Striebel as they discuss the syndrome of catatonia, its dynamic presentation, treatment strategies, and why clinicians should maintain a high index of suspicion when evaluating complex psychiatric symptoms.
Hello and welcome to another NEI podcast. And today we have a topic I'm really interested in talking about, and it's something we don't hear enough about in our training or even out in our clinical work. And we're going to be talking about catatonia, which is one of those symptoms that is kind of transdiagnostic. And with us today from California, from the California State Hospital System and UCLA, is Dr. Joan Striebel. Hello, Joan.
Good morning. Good morning, Andy. Thank you for inviting me.
Oh, I'm really happy to talk to you about this. And I understand that you know Dr. Stahl from, of course, working in the state hospital system. You may have come across another one of my friends, Dr. Jonathan Meyer. And I understand that we share a friend and mentor, Dr. Steve Martyr, who is, of course, extremely well known. Hopefully our audience knows who he is. Well, let's just start out with some basics. We use the word catatonia, but what does catatonia really mean in the clinical setting, and how does it look?
Oh, it's a fascinating syndrome. So it's a syndrome of specific motor abnormalities that are associated with disorders in mood, affect, cognition, and thought. And it presents in the context of an underlying disorder. There are three forms. The most common form is retarded, less common, excited, and then the most severe form, and fortunately also less common, is malignant catatonia.
Yeah, I think when most people hear the word catatonia, they think of the retarded type, someone who's catatonic with waxy flexibility, but it sounds like it can be at either end of the spectrum. Tell me what the excited form looks like.
So, let me just go back to the retarded form for a moment, because one of the signs of catatonia that is often really confusing for people is something called alternation. So people can move from a stuporous, sort of immobile, mute state to a very agitated, aggressive, impulsive state. And so this, if you're thinking about retarded catatonia as a static state, and you see this sudden alternation, you might think, oh, this person doesn't have catatonia. But in fact, alternation is really not seen in anything else, and it's really pathognomonic for catatonia.
Wow.
You ask about the excited catatonia, which is someone who is sort of engaging in ceaseless, purposeless motor activity. So constantly pacing, restless, can't sit still, agitated, and really may not have those classic signs of retarded catatonia, immobility, rigidity, that kind of thing.
Well, that's extremely helpful. I just learned something, Joan, because I didn't realize it could alternate like that. I kind of thought it was one thing or the other, not both. And you mentioned something else. It's not just movement. It can affect various other aspects. So are people less aware, less connected? Do they appear delirious, if you will? What's their cognitive state like?
You actually just described stupor. Less connected. So one of the signs of catatonia is stupor. And, in medical school, we learn about stupor on the continuum as right before coma. So there's stages of arousal, lethargy, there's obtunded, and then someone will become stuporous and then enter into a coma. That's not how we think about it in terms of catatonia, and you described it exactly how it is. Stupor is a state of unresponsiveness to external stimuli. People are simply unable to interact with their environment, but many patients are fully alert. So if staff are going by and they make a comment, a patient may be completely aware of that. And later, when the patient is sort of released from their catatonic state with lorazepam, they will be able to tell you what happened around them.
Wow, that's really important for staff to know, of course, not to assume that the person doesn't hear what they're saying. So be careful with your comments.
Yes.
Now, in describing the excited state, what came to my mind was akathisia. How do you differentiate this from akathisia?
So I think it's always important to remember the context. So when you have someone who is excited, you'll typically see some other signs of catatonia. Okay. So for example, let me describe this in the context of someone who's exhibiting this alternation of signs. Okay. So there was a patient he was incarcerated in a jail in Northern California, and I've done a lot of my work with catatonia, or recognition of catatonia in jails, prisons, and state hospitals. And so this man people would go by his cell, social workers, clinicians. They would call to him, "Hey, come to the door. Let's talk." No response.
I see.
Then he was being taken to court. So he's with the deputies. He's in the Sally Port and he's cuffed, but he's attempting to bite the deputies in the Sally Port. So he's going from this place of not really responding, possibly stupor, maybe mutism, to being very agitated in the Sally Port.
I see.
Then he's in court. The judge is talking with him. He's not responding.
I see.
The man then is transferred to one of our state hospitals, and he's running up and down the hallway, still mute. So he's not speaking with anyone. He's just pacing, running. So that's the excitement, catatonic excitement. He's engaging in public masturbation. And then right after that, the treatment team finds him lying on his back in bed. He won't look at them. He won't speak. And he doesn't really come to or awaken until he's given a lorazepam challenge. And after that challenge, he asks for chicken nuggets. So this is very common that someone who is in the midst of catatonia is given lorazepam. They sit up or stand up and maintain eye contact and ask for a meal.
Wow. So it sounds like that can be dramatically effective. And I want to talk about treatment in just a minute, if we could. But so what about, akathisia, the definition, of course, you have to have a subjective sense of restlessness. It's extremely uncomfortable. But it sounds like that may not be what's going on here.
Yes. And the patient, typically in catatonia, they're not going to be able to describe what they're experiencing, because often they're not speaking. When people are speaking, there's some speech abnormalities like veridiration, which is just repetition of meaningless words or phrases. There can be echolalia. So it's very difficult when someone is catatonic due to stupor and abnormalities with speech to have them describe their experience.
Yeah, and that's very different from akathisia when the patient is completely alert and responsive and can tell you, they can describe it. Okay, that's really helpful. Now, you used the term malignant catatonia. Help me understand, what is that?
Sure. Fortunately is rare. Unfortunately, the name for malignant catatonia before the name we use was lethal catatonia. So this is the most severe form of catatonia, and it's been recognized all the way back to the 1800s. And it's a syndrome of horrible motor excitement, along with hyperthermia and hypermetabolism that ultimately ends in stuporous exhaustion and before ECT treatment, which is very effective, often death.
Oh my goodness. Yeah, that makes perfect sense. So from that point of view, there's some overlap with NMS, of course. And I guess the key here is to look at the time course of medication and, is medication temporally related? And that would also help with akathisia, of course, too.
So there's a group, there's a bunch of modern giants in catatonia, Max Fink, Jonathan Taylor, Michael Allen Taylor, Jonathan Rogers, many of these folks. And there's a group that believes that NMS is actually malignant catatonia with a drug precipitant.
Oh my. Well, that is interesting. Then I guess I was right. There is clearly an overlap there. Okay. Yeah, Max Fink, of course, well known for ECT and other things as well, of course. All right, let's talk a little bit about how our understanding of catatonia has evolved. As you said, it's been described for a long time, but what have we learned over the years?
So, and we'll come back to Max Fink again because he was key in the evolution of, catatonia being separated from schizophrenia. Yes. So let's go way back. So catatonia was described in the writings of the early Greeks. As we come forward in time, all of the signs of catatonia, catalepsy, stupor, waxy flexibility, these were all described, but they were never really put together under one roof.
Oh, okay.
They were attributed, of course, as many things were back in the day, to the uterus and how vapors of the uterus would go and affect the brain, resulting in these motor symptoms. I'm not exactly sure how they described them, what the mechanism was for men, but that was what was hypothesized in women. Then Karl Kahlbaum comes into the picture, and he is the first one to actually describe these motor symptoms as part of what he called attention insanity that was due to other forms of insanity, but this tension insanity was catatonia, so increased tone.
I see. Yeah.
And he wrote the first book on catatonia, 1874, and described 26 cases, which are just beautiful representations of all of the signs of catatonia. We come forward a few more years in time to Kraepelin. And when Kraepelin he was a major figure in psychiatry. He established dementia praecox, bipolar illness, established the firewall between those two. And he wrote the textbook that basically carried the weight that the DSM carries today. So very influential, powerful textbook. And in the 6th edition of that textbook, he took independent illnesses such as catatonia, it was dementia paranoides, and then hepiphrenia, and they became subtypes of dementia praecox.
I see.
Unfortunately, this then changed how doctors looked at catatonia. It was always connected with schizophrenia. And as a form of dementia praecox, which ended in dementia, catatonia was thought to end in dementia.
I see.
Loyler also sort of continued this. And even though there was backlash in some academic circles, this continued all the way until 2009 with a really important paper that was authored by Max Fink and colleagues. Mm-hmm. And it wasn't until that paper, which outlined NMS, it outlined some of the other studies which saw far more catatonia in affective illnesses, and it described the presence of catatonia in non-psychotic illnesses, that things really began to change.
I see. Yeah, it's interesting. I mean, I obviously trained way before 2009, and I think I remember hearing that catatonia not only could be seen in affective and other disorders, but that it might be even more common in affective rather than schizophrenia.
Yeah, so there's a group working out of McMaster's University, Patricia Rosebush, Michael Mazurek, Sean Rasmussen, and others. And there's a wonderful paper that Rosebush and Mazurek published in 2010, and they really outline their case series of catatonia. So this was 148 patients that had been treated in their acute care hospital for over 20 years. They state in the paper, and I've read this paper so many times, they state the diagnosis was not questioned. They know that that the diagnosis was true. And when they looked at the episodes of catatonia in these patients, 46% of the catatonic patients had underlying affective disorders. Far less commonly were patients with psychosis. And then there were patients with medical or neurological cause who did not have a psychiatric comorbidity. Also, 4% of the patients were in benzodiazepine withdrawal. So a variety of different underlying diagnoses.
That is fascinating. Can you see catatonia in PTSD, for instance?
I have not seen that yet. And what is so curious about that is fear. So there's a wonderful history of catatonia that was written by Edward Shorter and Max Fink. It's called The Madness of Fear. And one of the ideas is that fear drives catatonia. So you think of PTSD and trauma and fear, and you wonder if there's a connection there. But I haven't seen PTSD as an underlying diagnosis for catatonia. Okay.
But certainly for our audience, what might be eye-opening is the fact that this is not just associated with schizophrenia or psychotic disorders, which is how a lot of people think about it, and I get it. You know, when you talk about that fear, you know, certainly we're all aware of when animals, let's say, or people can be paralyzed by fear, literally. And so that's a form of a catatonic state, I suppose.
Yeah, so you think about scared stiff.
Scared stiff, right.
You know, thunderstruck.
Yeah.
So there are this language these adages that have been passed down, and you wonder if they didn't have their origin, you know, when catatonia was first observed, but didn't have a name yet.
Yeah, absolutely. Wow. Okay, let's talk a little bit about neurobiology. What do we know about the neurobiology of catatonia?
Oh, this is in progress. So, the exact mechanisms are still unknown. There are a variety of different hypotheses. So because lorazepam and some barbiturates have been so effective, there's the idea that it's related to GABA. There's ideas that it's an imbalance between GABA and glutamate signaling. There was just recently a paper that was published in Schizophrenia Research that is proposing mechanisms related to inflammation and oxidative stress. So this was coming from the group at Massachusetts General Hospital, a big catatonia research group there. And they're looking at, you know, inflammation in depressive disorder, inflammation in schizophrenia, even inflammation in autism, because up to 20% of patients with autism will often develop catatonia. So lots of sort of foundation there. And thinking about how in inflammation there can be sort of damaged proteins that interact with the immune system, cytokine release, a sort of porous blood-brain barrier that allows cytokines to interact with cells, resident cells of the CNS, and then result in these dysfunctional neural circuits. So a variety of different hypotheses.
Well, that certainly makes sense. I mean, we know that inflammation can have negative consequences on both the glutamate and the GABA system, for instance. But, you know, I'm also thinking about dopamine here. Of course, dopamine is involved in the coordination of movement, in cognition, and mood. So obviously, dopamine might be a player somehow in here too. But you're right. I'm sure there's a lot to learn, I'm sure.
And especially if you're part of the group that considers NMS as part of malignant catatonia, because you've got the either treatment with a dopamine receptor blocking agent, either antipsychotics or antiemetics. And then also NMS is seen on withdrawal of a dopamine agonist like levodopa.
That's right. Interesting. So many possible theories here. Are there assessment tools that help, or is this just a clinical diagnosis, or is there a way of staging it?
Well, to be honest with you, I have seen a lot of catatonia, and I've never used a rating scale.
That's fine.
And I think the most important point is that, and this is also discussed in the wonderful Rosebush paper, that treatment of catatonia, that it's a clinical diagnosis, as you mentioned. And once you see a couple of signs, move towards the lorazepam challenge, because patients being catatonic, I can't even imagine how terrifying it must be to be aware, but not to be able to respond. Many people are also psychotic and are, if we're thinking about fear, must be terrified. So research scales are wonderful, but as long as they don't delay treatment. So there are a couple of really important scales. One is the Bush-Francis Catatonia Rating Scale. And I will put in a plug for a wonderful educational resource. If you if you Google the University of Rochester catatonia videos, these are a series of videos for every criteria on that scale. So these are videos done by Mark Oldham and Jonathan Wartzel. Wartzel is the standardized patient, and Oldham interviews him and does the motor exam. They're just wonderful videos. And so if you're not sure what waxy flexibility or Midgehen or Gegenhalten is, they will show you. The Bush-Francis scale technically is a 23-item scale. It goes down the motor and some of the other signs of catatonia. And the first 14 items function as a screen. 2 positive out of 14 are required for diagnosis.
Only 2.
So that's that scale. The other scale that's commonly used is the Northoff Catatonia Rating Scale. And they actually divide symptoms and signs into motor, behavioral, and affective, and they require one of each to diagnose catatonia.
Well, that's helpful, again, in the concept that this is more than just motor. I think that's helpful. I think one of the main things I hope our audience gets out of this, Joan, is have a high index of suspicion and know what you're seeing, because it does sound like there's effective treatment, but if you're not aware of the effectiveness of benzodiazepines, let's say, you're not going to be able. You might increase the dose of an antipsychotic or do something else that's not as effective.
Yeah, so one of the big problems with catatonia is we aren't. I think residency education on catatonia is catching up. And I think with the videos from the University of Rochester, there's major improvement in education there. Yeah. But I never saw a catatonic patient when I was a resident. Weren't there any? No,
of course.
Because up to 10% of patients who are admitted to inpatient psychiatric units are catatonic. Right. I didn't miss them. Exactly. And it wasn't until I got into, working in forensic systems that I began to recognize catatonia.
Yeah.
This was just, I mentioned the story of the patient who was at one of the jails who was the alternation. So that doc missed it because he even wrote in his note that, the patient just wasn't in tune with the environment, aware, responding. And one of the nurses clapped loudly behind the patient to try to startle him. And the doc wrote, to jolt him from his stupor. The doc used a catatonic term,
right.
A sign of catatonia, stupor, but he never made the diagnosis.
No. Certainly people that trained in my era, we were not, I only saw one patient in my whole training that was identified as catatonia, and it was a very obvious case of waxy flexibility. And I'm sure, as you said, there were many others, and we just didn't realize. And that's why I'm saying this is so wonderful. We're talking about this, that hopefully our audience will now have a higher index of suspicion and will consider this more in their differential. I'd like to go back real quickly. You mentioned two incredible resources. The first was, you mentioned that terrific paper. Was it by Rosenbach?
Oh, Rosebush, Patricia Rosebush and Michael Mazurek. So this is, it's funny. It's a 2010 paper. It's not a new paper, but they give such a nice discussion of the lorazepam challenge, how to do a proper lorazepam challenge, how catatonia presents. And another researcher in their group, Sean Rasmussen, has also published a paper that is a description of catatonia and response to benzodiazepines, which varies depending upon the underlying illness. There are a number of wonderful books that have come out. Catatonia, A Clinician's Guide to Diagnosis and Treatment by Max Fink and Michael Allen Taylor. Yeah. This is just a fantastic, very readable guide to diagnosing and treating catatonia. There's another, Catatonia from Psychopathology to Neuropathology by Stanley Karoff and others, another more recent book.
We have to stop right there. Stan Karoff is one of my absolute favorite people. I've co-published with him around tardive dyskinesia, and he's someone who I don't think has gotten enough recognition. He's been publishing away in almost obscurity until 2017 when we got the VMAT2 inhibitors and suddenly we rediscovered TD. So thanks for mentioning him.
So he actually has two books that I love. So he's actually somebody who I consider a giant in catatonia. The first is neuroleptic malignant syndrome and related conditions. So in that text, he talks about malignant catatonia. And then is the other book that I just mentioned, Catatonia from Psychopathology to Neurobiology.
Okay, great. What terrific resources. Thank you. I wanted to put a pin in those so their audience could know. And then the other one, of course, those videos. And the analogy here again with tardive dyskinesia, the videos have been so helpful in training and teaching people about tardive dyskinesia, which, again, a lot of us were trained in a very narrow way. We were taught to look for oral buccal lingual dyskinesia. That was it. But my gosh, it can present in so many different ways in any part of the body. So I want to put a pin in that one as well from the University of Rochester, those videos.
Yes.
So people, can see it. It's one thing for us to describe it, but I think you're right. To see it is really the best way to learn about this. All right, we have talked about benzodiazepines indirectly. Let's really focus in. I was trained that lorazepam was the treatment for catatonia, even though we didn't see it. We didn't think we saw it that often. Tell me about benzodiazepines. How effective are they? Maybe why do they work? What's the thinking behind that?
Sure. So they haven't always been the treatment. Just thinking back in time, benzodiazepines, 1960, lorazepam, even though I think it was patented in 1960, actually wasn't marketed until 1977. And it wasn't actually used to treat catatonia. It was somewhat serendipitous, but 1983 was the first report. And that came out of Mass General, their consult and liaison service. Mm-hmm. So prior to the benzodiazepines, it was, a grab bag, bloodletting, opioids, cocaine was used.
Oh, goodness.
Then there were the barbiturates, which, so they allowed a brief reprieve, but if they weren't continued, the patient would relapse to a catatonic state. And then convulsive therapy. So they were really right after the barbiturates, and they offered a definitive treatment.
Yes.
So then coming forward to the benzodiazepines, the case report, it was actually 4 patients. And I think this is just fascinating when you go back and look at the history of these medications. So this was consult liaison. These were medical patients.
Was this Ned Kasem? Was he one of them?
Yes.
Yeah, because I think I actually read that in my residency, that paper.
Yes. Yeah. And the first author, I don't want to mispronounce his last name, but he is another giant in Catatonia, Gregory Friccioni.
Okay. Great.
So I think he might have been a resident or at that point in time. And then Kasem was the attending. Yeah. So these are patients on CL. They develop some post-operative agitation. They're given haloperidol. They develop signs of catatonia. So they're given, first anticholinergics didn't work, and then given a benzodiazepine, which rapidly resolved symptoms.
Wow.
And after the first patient, the other 4 were also given the benzodiazepine, same effect. So then it began to be recommended for catatonia.
Right.
So these are, they're agents that work on the GABA A receptor. We most commonly use lorazepam. This is a high potency sort of medium half-life agent. When it's given IM, it reaches, or given IV, which is ideal, it reaches a peak plasma level very quickly. So very rapid onset of action with resolution of symptoms in often just minutes. Right. In the prison system and in the state hospitals, we'll usually use it IM.
IM, sure.
And so we'll get resolution or diminishment of symptoms in maybe 30 minutes. I had one man, it took a bit longer, 45 minutes. And Rosebush and colleagues, they recommend you wait 3 hours after the first challenge. And if there's no effect or partial effect, give another injection in 3 hours and then a third 3 hours later for a full trial or lorazepam challenge.
And what kind of dose are we talking about? 2 milligrams or something?
2 milligrams for a healthy adult. There was a patient that perhaps I'll be able to talk about him a bit later, who was very decompensated, who had lost quite a bit of weight due to a prolonged period of catatonia. He was an older man, and we started with 1 milligram for him.
Okay.
So maybe children, adolescents, lesser doses, but 2 milligrams for the average adult.
Sure. And then how long do we need to keep giving it? Will it resolve after benzodiazepine treatment, or is it just an individual case by case?
So it is given as a challenge, and then based on response, the benzodiazepines are usually continued. And remember, one of the things that people forget is that catatonia it's always related to an underlying illness. So that underlying illness needs to be treated.
Okay.
And so the benzodiazepine is given, the patient responds, the signs of catatonia resolve, but now it's time to treat the underlying illness. If the benzodiazepine is discontinued and the underlying illness is not treated, the patient will relapse into a catatonic state.
Okay, got it. That makes perfect sense. You know, benzodiazepines now, of course, have stigma and baggage, and some people are reluctant to use them, and especially I would think they'd be reluctant to just sort of chronically continue. A lot of these patients, of course, have substance abuse issues. So it's sort of reassuring to think this may be a short-term treatment while you're getting the underlying condition under control. So you don't necessarily have to continue them permanently for everyone, if you will.
Yes. And I think the problem is because of the stigma and because people are worried about side effects like respiratory depression and sedation, many docs are just hesitant to titrate to the kind of doses that patients require. Right. So in some patients, very high doses are required, 8, 16, 24 milligrams a day. Yeah. And I remember being called, this was in the last couple of months, by actually Dr. Stahl had asked this doc to contact me. The doc was treating a patient who was traveling, who was catatonic, and had to prescribe lorazepam 16 milligrams a day in divided doses. And the pharmacy was giving the doc pushback.
I'll bet.
And he didn't know what to do.
Yeah. Yeah. That's unfortunately controlled substances these days are harder to prescribe. Well, and so you mentioned a little bit about why lorazepam, but would other benzodiazepines potentially also be effective? I know one of the advantages of lorazepam is very easy to give parenterally, has essentially no hepatic metabolism, but would others also work?
Yes, you can use clonazepam. I hesitate with drugs like diazepam because of the very long half-life, active metabolites, that kind of thing. And so lorazepam, clonazepam. The other possibility is zolpidem.
Oh, interesting.
Yes, there's another wonderful resource. Sorry, I'm full of wonderful resources.
No, that's great.
This is a 2023 paper by Jonathan Rogers, along with other catatonia giants, and it's the guidelines for treatment of catatonia from the UK. And so he goes down all the medications that have been effective, including zolpidem, which is also a medication that is a sort of a GABA A medication.
Yeah,
so
these are GABA A partial allosteric modulators. Yeah.
Yes, so gabapentin can be, zolpidem can be used as a challenge and then also as continuation while the underlying disorder is treated.
But to my knowledge, zolpidem is oral. Is there a parenteral version, or this is for a patient who can take a pill?
It is oral, yes.
Okay, yeah. Now, you slipped and said gabapentin. That was going to be one of my questions. Has gabapentin been looked at?
No. it may have been looked at, but it's not effective.
It's not effective. Now, that's so fascinating, isn't it?
Well, because it doesn't really act on the GABA receptor.
That's right.
Yeah.
It's sort of GABAergic in an indirect way, yeah. All right. What other? We've mentioned a few others. Are there other pharmacologic interventions? You've mentioned several before we get to ECT, which of course we need to talk about. But is there anything else we should consider, or just sounds like lorazepam can be so darn effective?
Lorazepam is, I love how you said that, so darn effective. So when you actually look at the response rate to lorazepam, upwards of 90% of patients with a bipolar illness as the underlying cause or the driver of catatonia will respond to lorazepam. I think still over 90% with unipolar depression. The response rate for psychotic disorders is less, but still over 50%. So very effective, particularly in the mood disorders. Yeah. Other medications, amantadine. So they're thinking that between the dopamine agonism and some of its other mechanisms.
NMDA. Yeah, it's an NMDA antagonist. Yeah, glutamate.
Possibly. I know on some algorithms, carbamazepine is also part of the algorithm. So those are two other possibilities.
Okay, great. That's really helpful. There's something else you just said, Joan, that I think is really important. I think some people may assume catatonia happens only when a bipolar patient is manic, but certainly in the depressed phase, and you even mentioned unipolar MDD. So you can see catatonia in the depressed phase as well, correct?
Yes, and you can see it when bipolar illness is not treated. So I've talked about a lot of cases, but I have just a fantastic case, if I may.
Please. We love hearing cases.
This was a man, middle-aged man. He was in a carceral setting, and when he presented to an inpatient hospital, so there are certain prisons that have inpatient psychiatric hospitals that are within the prison environment. Right. So he presents, he appears psychotic. He's refusing oral medication. So they start haloperidol decanoate. Several months later, the treatment team calls me. This is when I'm working as a consultant. And the psychologist describes the man as lying in his bed. He's on his back. He's flexed his waist about 30 degrees above the plane of the bed. Wow. So he's resting his upper torso and head as if on a pillow of air. This is called the pillow posture. This man is posturing, sign of catatonia. Pillow posture is not all that common, but she described it perfectly. Yeah. He also wasn't responding. So treatment team comes by, knocks on the door, nothing. He's disrobed. He's just laying there, for extended periods of time. And I don't know, I'm thinking about myself and ab exercises. This is difficult to maintain.
Difficult to sustain that posture.
Yes,
right?
Yes. So immediately when I hear all of this, I recommend that they do a lorazepam challenge and, classic response. So, within 30 minutes of the injection, he's sitting on the side of his bed. He's putting his clothes on. He goes to the door. Wow. And he also requests lunch. And this is the first time he's talked with his treatment team in months. As I began to look back at the case, there was very clear evidence of manic episodes, so he was described in other inpatient settings as sort of climbing on the shower walls, screaming all night, just very clear manic behavior. And what my hypothesis is this man was Black. We know that bipolar disorder is underdiagnosed in Black populations.
Of course.
I suspect that he was diagnosed with a psychotic disorder, possibly schizoaffective bipolar type, but that the bipolar piece of his illness wasn't considered to be as prominent as I think it was. So he was treated with antipsychotics, which really didn't treat. He really needed a first-line mood stabilizer. Right. We started lithium, and then as his mood disorder was adequately treated, the lorazepam was able to be tapered.
Wow, that is a terrific case. Thank you. That's a great example.
It's a great example because the haloperidol was not effective.
Right. Absolutely right. Yeah. What's an interesting observation I've made recently, Joan? All antipsychotics are antipsychotic, but they're not all antidepressant. So some of the newer atypicals may be more effective for bipolar, especially both poles. I mean, all antipsychotics are anti-manic as well, pretty much. We know that. So that's another interesting thought. Let's shift gears now and talk about ECT. How does ECT work and how effective is it? And when would you use that?
Very effective. So the history of ECT in catatonia really goes back to Meduna, way back when they were using camphor and other ways of achieving convulsions. And, his first patient had signs of catatonia that were resolved. When they began to use electrical or induce seizures electrically, this was Bini and Cerletti. Their original first patients also had signs of catatonia. Mm-hmm. When ECT or convulsive therapy came to the U.S., this was the 1940s, it became then, like before benzodiazepines, the definitive treatment for catatonia. Yeah. And so now it's first-line treatment for malignant catatonia.
Sure.
It's also used in some areas where it's available easily as first line for neuroleptic malignant syndrome. Yes. And then also for patients who have a partial response to benzodiazepines or in whom benzodiazepines just fail completely.
Right. Well, that's interesting. You slipped something else in there. So ECT is effective for NMS. I was not aware of that. So that's another good learning point here. We talked about people may not realize the risks of not recognizing or treating catatonia. I mean, certainly you mentioned, especially in the case of malignant catatonia, but there's also perhaps damage to the underlying condition. There's the psychological impact on a patient. Can you talk a little bit about those things?
Yeah, so I think this is because of the nature of my work and where I've worked, I've seen some horrific cases, and these have really disturbed me. And so I can tell you from the sort of minor symptoms, consequences of untreated catatonia, all the way to very horrific situations that are shocking to believe that could occur in 2023, 2024 is when I saw these cases.
Yeah.
So, often in the prison system, patients will decline medications. They will decline antipsychotics. There's no compelling evidence to support an involuntary medication order, so they go out to the general population. And out in the general population, they will come to the attention of custody, who will notice either their behavior is off or something else. And I remember one young man, custody noticed that both of his lower legs were incredibly swollen and, erythematous. So he was sent to the prison equivalent of the urgent care. They did the complete medical workup for this lower extremity, just profound edema and swelling. Didn't find anything, but then a nurse found him one night when she was doing rounds, just standing in his cell. And so this lower extremity swelling and dermatitis was a consequence of immobility, prolonged immobility, standing, due to unrecognized, untreated catatonia.
Wow.
So going a bit farther in terms of severity, when someone is not moving for long periods of time, I saw a patient who had been observed to be in the lotus position for an entire shift. Shift is 8 hours, sitting in a cross-legged position for 8 hours. Not something that I could manage. But you think about stasis. This man had developed a DVT. Then it progressed, traveled, pulmonary emboli, cardiovascular arrest or cardiorespiratory arrest, developed an anoxic brain injury, life support. Eventually the man died. So severe consequences.
Sure.
You think about the misdiagnosis, under recognition of catatonia. There was another man who presented with stiffness. This was thought to be Parkinson's disease. So he was treated with large doses of dopamine agonists. There was no improvement. Finally, these were withdrawn. And when I got the call, the team was considering putting him into hospice. I went down, saw the man. There were many signs of catatonia, gave him lorazepam. He awakened, within 45 minutes of the injection. But he had been catatonic for months. He had lost 44% of his total body weight. Due to immobility, he had developed contractures. I think his renal function had also been compromised. This was a man who would probably never walk again because of the contractures, the muscle loss, the long period of time spent in catatonic immobility. And, in terms of consequence, what's going through the patient's mind, this man described just horrifying sort of delusions of ants crawling on his legs, and he's immobile. He's not able to brush them off. So just so terrifying. Much impetus for us as clinicians to really study this, to look at those videos, get a guidebook and look carefully in patients so that we don't miss this and cause them serious harm.
Absolutely. Another thing to consider in the differential case I saw several years ago, I admitted a patient to the inpatient service that had schizophrenia, a youngish man, and I started an antipsychotic. The next morning I came in and he was seated in a chair in front of the nurse's station and he was staring up at the ceiling. And I said, "What's going on here?" And they said, "Oh, he just will not cooperate. He won't look at us when we talk and this and that." And it turned out it was an oculogyrate crisis or an acute dystonia. And I said, "Well, okay, while we're doing this, let's just give him an injection of Benadryl and see what happens, diphenhydramine." And of course, he came right out of it and said, "Oh my God, that was terrifying." So I guess there's overlap with dystonias. Obviously, the key there was just starting an antipsychotic that was clearly antipsychotic related.
Yes.
Okay.
Wait, you also bring up such a great point, which is when things are just attributed to behavior.
Yes, that's my point in a sense.
He just won't look at us.
That's right.
Like it's volitional. And
Exactly.
I think that that's another reason for misdiagnosis in catatonia. We didn't get a chance to talk about negativism, but often when people are demonstrating negativistic behaviors, they're thought to be volitional, but this is part of catatonia. It's such an important sign of catatonia.
Right. Exactly. And this is why I really want to, again, have our audience have a high index of suspicion here and maybe talk with your staff about this as well, that, this is not always behavioral and it's not always volitional. Okay. As we're getting close to wrapping up here, of course, I always like to end with the future. And what kinds of research directions are there, and are there new treatments being looked at?
So one of the big problems with this is that because we still don't have great evidence regarding pathophysiology, it's really hard to know what to target in terms of developing a novel treatment.
Right.
Because ECT is so effective, the non-invasive brain stimulation therapies, repetitive transcranial magnetic stimulation, and direct current stimulation, these are being investigated. There's some case reports and small case series. I know that there are some trials that are currently enrolling. I think the direct current stimulation may be interesting because there's sort of a parallel with negative symptoms in schizophrenia and the dorsolateral prefrontal cortex and the ability to stimulate that with direct current stimulation. So there's a small case series. They saw improvements after using direct current stimulation. The most of the group was between 40 and 60% improvement, and that was a decrease in the rating on the Bush-Francis catatonia rating scale, so important use of that scale. One person actually did very well, 100% improvement. I think what was interesting about that case series is a couple of the people responded well enough so that they didn't need ECT. A couple people responded and then relapsed when direct current stimulation was discontinued, indicating that maybe maintenance direct current stimulation was required. We know that in some people with catatonia that's only partially responsive do require maintenance ECT. This is ECT that goes on for perhaps years on a less frequent basis. So these are some interesting research directions.
Absolutely. Yeah, I was going to ask about that, as a matter of fact, about ECT, like with lorazepam. So it sounds like it's not necessarily ongoing for most patients, but maybe for some.
Yes, it is for some. They are few and far between, but some people do require ongoing lorazepam or clonazepam. And there are, the people that have severe catatonia that really doesn't respond to benzodiazepines, and they're in forensic settings or even outpatient settings where there's an ECT center that's local. They can get maintenance ECT. I know that we may have one or two in the state hospital system where we do have at a couple of the state hospitals an ECT service. So it's possible that they will be getting ECT once every 2 weeks, perhaps less frequently, but it can go on for many years.
Okay, great. Well, this has been incredibly educational and fascinating, and I have to give a shout out. I want to thank a colleague of ours, Michael McNamara, Mike, who's a psychiatrist up in New Hampshire. And he had come up to me at an NEI meeting and said, you know what, you guys need to have a session on catatonia. We never hear anything about catatonia. So, Mike, I want to thank you for bringing this to our attention. And I really want to thank you, Joan. This has been tremendously helpful. So thanks so much for your time and lending your expertise.
Well, thank you. I'm definitely... my level of expertise is definitely just on the clinical side. And, I have so many people that I admire and I have so much respect for, and I've tried to name some of them as I've spoken, but they are really the people that we should be reading and speaking on the podcast. But thank you.
Well, sure. Well, again, this is an underappreciated clinical issue that sounds like it's more common than we realize. It can be seen in a variety of conditions. We didn't mention neurodevelopmental disorders, but it can be seen there as well.
Absolutely. In up to autism spectrum disorders, in up to 20% of those patients, in other sort of genetic disorders, I know as well. And I think it's difficult in those disorders because sometimes the signs of catatonia can overlap with things that you might see in autism. So it can be difficult to tease apart.
Yeah. Well, again, I hope we've kind of given our audience something to think about and raised their awareness. And again, I want to thank you so much for your time. And I want to thank you, the audience, for listening. I hope you found this valuable and certainly helpful in your clinical work. And I hope you will check out more of our podcasts. This one kind of fits in with a series we've been doing on transdiagnostic and underappreciated clinical conditions. For more information about our various educational offerings, please go to our website, which is NEIglobal.com. It's NEIglobal.com. And you can find our podcasts anywhere you get podcasts. You can search for NEI Psychopharm or my name, Dr. Andy Cutler, since I moderate most of them. Joan, thanks again, and thank you for listening.
You're welcome. Thank you, Andy.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.